Yeah, welcome to my session on frameworks and contexts at scale in the Kerala Diabetes Prevention Program. So, my name is Thankappan, K.R. Thankappan. I'm a public health physician working in India. So, before I start my presentation, I just show you some selected health indicators for Kerala and India, just to contextualize the Kerala state within India. For example, the infant mortality rate of Kerala is 6 per 1,000 live births compared to 28 per 1,000 live births in India. The crude birth rate is 13.2 compared to 19.5, and life expectancy 75 years at birth for Kerala and 70 years for India as a whole. And the diabetes prevalence, I am talking on diabetes, Kerala Diabetes Prevention Program. So the diabetes prevalence is 25.5% compared to 11.4% for India as a whole, more than 2 times the national average. So diabetes prevention programs in Finland, USA, and China have demonstrated a reduction in type 2 diabetes incidence between 42 to 58%. In the Kerala Diabetes Prevention Program, KDPP, after a median follow-up of 24 months, diabetes developed in 17.1% of 507 control participants and 14.9% of 500 intervention participants. The incidence of diabetes in the impaired glucose tolerance subgroup was significantly lower in the intervention group. So compared with the control group, intervention participants had a significant reduction in major cardiovascular risk factors, a significant increase in physical functioning score of the health-related quality of life. So we had in the Kerala Diabetes Prevention Program a cultural adaptation for the KDPP study. The KDPP was adapted to Kerala from evidence-based lifestyle interventions implemented in high-income countries, namely Finland, USA, and Australia. So the adoption process included needs assessment, formulation of program objectives, program adaptation and development, piloting of the program and its delivery, program refinement, and active implementation. So that was the brief of the overall Kerala Diabetes Prevention Program study. Now we will discuss about the scaling up of the KDPP study. So the objectives of the KDPP study was to develop a program delivery model for diabetes prevention and related capacity building in the Indian state of Kerala that can be further scaled up to all of India in the future, to achieve significant improvements in the behavioral risk factors. So the methodology was, this was conducted in partnership with the Kerala Kudumbashree State Mission, which is, and Kudumbashree State Mission is the largest women's organization with more than 4.2 million members spread all over the state. 3 geographically and culturally distinct districts were selected. One is from the south, center, and northern Kerala. Approximately 3 million population in each of the district. In each district, the plan was to train 40 KSM trainers. Each KSM trainer was expected to train 125 peer leaders of neighborhood groups. In each district, 5,000 peer leaders were trained, making a total of 15,000 in the state. As I said, these are the 3 districts, the blue ones in the north in Kannur, in central part of Kerala, Ernakulam, and southern part of Kerala, Kollam. So methodology continued. Each peer leader was expected to take 12 monthly sessions to their neighborhood groups over 1 year. A neighborhood group consists of nearly 25 women. Thus, we plan to reach at least 375,000 women and their family members over a period of 1 year. The materials for the sessions were adapted from the KDPP RCT, randomized control trial, and modified and distributed by the community development chairpersons to the peer leaders. So these are the 3 districts, and the trainers trained were in Kollam, 150 trainers were trained, and Ernakulam 180, and Kannur 200 trainers. And 5,000 plus neighborhood groups in each of these districts. And we had a state level pilot training program that was in 2016, training of KSM trainers and training of peer leaders. And second phase was district level training, training of KSM trainers, and the phase 3 was block level training. So this is the geographical distribution and also the vertical structures of the Kerala state and the district state. State level training, district level, and then sub-district or block level training. The KDPP study was inaugurated by Dr. K.T. Jelly, Honorable Minister for Local Administration, and also the member of the Legislative Assembly in the Kerala Legislative Assembly, Advocate B. Aisha Poti presided over the function. So this is the political commitment for the program. Unless you have a political commitment, political support, this kind of scale up will be very, very difficult. You can see a large number of Kudumbasri peer leaders and members who attended the inaugural function of the KDPP scale up. Resources distributed to KDPP study participants. Training manual, flip chart, measuring tapes. And then the peer leader training manual, flip chart, measuring tapes, report form for 12 monthly sessions were also distributed. And the participants receive classes, no resources. And the data collectors were given weighing scales and measuring tapes for height and weight measurement, base circumference measurements. So the contents of the small group, 12 small group sessions. One is the inaugural meeting. Second was how to control diabetes, prevention of diabetes and overview, and self-modification, and identifying the components of the diet that require modification and goal setting of diet, identifying the components in physical activity behavior that requires modification, goal evaluation on diet, goal evaluation on physical activity, that was 8th session, tobacco use and alcohol consumption and how to reduce them, sharing of the changes made in individual lifestyle with the group members. They will share their achievements, goal targets, achievements, etc. And the 11th session was evaluation of goal attainment. And the last session was evaluation of the program impact at the individual and the community level. So for the behavioral evaluation, we had 1,200 participants, 400 per district. Were selected using systematic random sampling and interviewed before and after the intervention. 60 neighborhood groups, 20 per district, 3 districts, were selected to collect baseline and 1 year post-intervention data. All participants, women and family members from the 60 selected neighborhood groups, NGOs, were invited to participate. Participants unwilling to provide consent or unable to contact on 3rd consecutive house visit were considered as unavailable to participate in the study. Clinical and biochemical evaluation. 24 out of 60 randomly selected neighborhood groups were chosen for blood test and clinical measurements. At least 13 individuals per neighborhood group, 7 women and 6 men, were randomly selected, totaling 312 participants. 387 individuals participated in the baseline study and 321 participated in the post-intervention evaluation. So all measurements were provided free of charge at mobile clinics, very close to their homes. So measurement domains and survey tools and baseline and 12 months after the intervention. So demographic measures, age, sex, education, occupation, and monthly household expenditure. Scalability, we use the RE-AIM framework: reach, effectiveness, adoption, implementation, and maintenance. Behavioral measures, physical activity, modified physical activity, global physical activity questionnaire. Tobacco use, WHO steps question. Alcohol use, also WHO steps question, and diet modified food frequency question. Clinical measures, waist circumference and weight. And biochemical measures, fasting blood sugar, 2-hour OGTT, oral glucose tolerance test, lipid profile, total cholesterol, HDL cholesterol, LDL cholesterol, and triglycerides. So the outcomes were primary scale-up RE-AIM framework, incidence of type 2 diabetes mellitus, fasting blood sugar, 2-hour OGTT test, and secondary outcomes were glycemic control, fasting glucose, post-load glucose, a lipid profile, total cholesterol, triglycerides, HDL, LDL cholesterol, and behavioral measures, diet, physical activity, tobacco use, and alcohol use. So the major findings after a follow-up of 12 months. 118 KSM trainers of 3 districts trained. We wanted actually to train 120, so we are short of 2. And 15,226 peer leaders were trained. You can see the district-wide distribution, more than 5,000 in each district. So we achieved more than 15,000. And neighborhood groups, 15,000 to, sorry, 226 neighborhood groups were established in the state. Each peer leader provided training to an average of 25 people in a neighborhood group, reaching a total of 380,650 women and their families. Out of the 387 participants in the baseline, 23% had diabetes, fasting blood sugar more than or equal to 126 milligram per deciliter. At the time, the diabetes prevalence in Kerala was only 19. But now, as I showed in the second slide, diabetes has increased to 25.5%. But at the time when we did the study, diabetes prevalence was more in this group. This is a poor group, and this was higher in the poor group compared to the general population. 38.5% had pre-diabetes. That is fasting blood sugar 100 to 125 milligram per day as per the American Diabetes Association guideline. Major findings continue. Compared with the baseline evaluation, post-intervention evaluation showed a greater increase in fruit and vegetable intake, physical activity increased, and there was a reduction in alcohol use, body weight, waist circumference, and total cholesterol. So what was adapted to the new context? So emphasis on peer support through group rather than individual contacts. Group members were mostly women, and the effort was to change behavior through them. Now, you know, in India, most of the cooking is done by women. So I think we wanted to change the dietary behavior through women. Participation of men was limited. Dietary behavior change can be better improved through women in Kerala. How was the adaptation process conducted? Formative evaluation, interviews with the professionals, administrators, and those with the diabetes. State level steering committee, we had a state level steering committee including all the major stakeholders. And we had district level implementation committee with the district panchayat president, district KSM mission coordinator, and all the other stakeholders. How was the adaptation and implementation evaluated in the new context? First level of the effectiveness of scale-up. This was done through the number of peer leaders expected to be trained and actual number trained. Number of sessions conducted by each peer leader in each of the 15,000 neighborhood groups. Number participated in each of the groups. And second level on change in risk factors. Change in behavioral risk factors after 1 year intervention, and change in clinical and biochemical risk factors. So major learning so far, how would you do things differently next time? Scale up was successful and reached 15,000 peer leaders and their families. Outcome evaluation was difficult as we were unable to collect most of the feedback forms from the field. The voice feedback system to monitor the effectiveness of the monthly sessions was difficult due to low response rate from the participants. So next time, we should focus on feedback forms at the beginning and reiterate during the implementation phase. Integrate the intervention program with the government health system, particularly with the lower level functionaries such as the accredited social health activists, ASHAs. So this is the KDPP overall timeline. So we started with the program objectives. And we had a needs assessment, which was published. And we had an intervention component, which was culturally adapted from the high income countries and feasible and acceptable. Then we had outcomes, 2 papers, most important papers on effectiveness and cost effectiveness. 2 papers were published. And we scaled up the KDPP to 375,000 people in Kerala. And we are now following these people, 1,000 plus population after 9 years. And we have already finished 85% of the population. It is, and we are analyzing the data now for finding out the long-term effectiveness. So in conclusion, the key messages are diabetes is one of the major NCDs in Kerala. As we have seen, 26% of adults in Kerala have diabetes, and this is an ideal condition for scaling up for prevention in the state. One of the largest women's groups in Kerala, the Kavumpurathu State Mission, and an institution of national importance, Sri Chitra Tirunal Institute for Medical Sciences and Technology, collaborated to implement the scale-up. Important to have political support. The Kerala government supported this program and used existing resources of the Kavumpurathu State Mission, making it cost-effective and sustainable. Thank you very much for your attention.